presentation. So I am an associate program director at the ISU base program, as well as program director of our rural tracks in Rexburg and Rupert. But in addition to that, I also started our wilderness medicine area of concentration for the residents. We're currently working on starting a wilderness medicine fellowship. And we are, part of that is that I drag residents onto ski patrol in my other position as medical advisor for the Pebble Creek Ski Patrol. So I'd like to think that I'm invested in some of the care that we provide pre-hospital, particularly at our ski area. So I'm going to first invite, just looking at people in the audience, could you give me a show of hands if anyone happens to be a medical director, medical advisor for any of our ski patrols throughout Idaho? Anybody? Okay. I'm seeing none in the audience popping up. Okay, just wondering. I'm going to share my screen now. There we go. So I admit I developed this slideshow in partnership with my colleague, Luke Nelson, who, in addition to being a PA and having his diploma in mountain medicine and fellowship in the Academy of Wilderness Medicine, is also an internationally famous ultra runner. So he's running this weekend and not giving this presentation with me. So you will have to forgive me as I perhaps need to fill in some spaces that he usually does the talking. So this is where we start. Radio call, 1:16 in the afternoon, almost exactly 3 years ago, oddly enough for the timing of this talk. CPR in progress, please respond. That is not the radio call I ever want to hear at a ski area. Let's back up to the objectives. We're going to specifically talk about the understandings and challenges. I want you to understand the challenges and limitations of pre-EMS care in a ski area specifically. I want you to have an understanding of the equipment and medical supplies used by ski patrollers. Talk about how we responded to the Canal Street avalanche. And then I want you to really gain an appreciation for how we frame and reframe traumatic stress for responders, as well as healthcare professionals, because I think that honestly, this whole talk is a not so sneaky way of actually talking about our professional wellness. So let's back up and give you some information about Pebble Creek Ski Patrol. This is a 91-member ski patrol. They are predominantly volunteers. They have anywhere from 0 to 50 years of experience. And they range, I mean, from medical professionals to tractor salesmen, literally. And we do have his permission to share that specifically. So you have a whole range of people's experience in their professional lives outside of their volunteering. All of them are certified as outdoor emergency care technicians, which is the National Ski Patrol standard. It's essentially an EMT basic plus some wilderness medicine training. This is Pebble Creek. It is a small local resort, but at the same time, it has, you can see it has an over 2,000 foot elevation. Total elevation at the top is 8,560 feet. Most of our upper mountain is a lot of black diamonds. This is the one green cat track to the bottom. We see a lot of very experienced skiers. And then we have some side country that is clearly marked not patrolled, not patrolled. And you can see that there's a lot of people also who will go over this ridgeline, ski off the back. We're a very popular side country, backcountry access point as well. The thing to realize as a ski patroller, as opposed to just a skier, is we are constantly thinking about if there is an accident, let's say on Rattlesnake Run here, we're thinking about how do we potentially extricate a person with a broken leg from Rattlesnake. The way we do that is with a toboggan. So this is a look at what our toboggans are and what's in them. They are stationed all over the mountain. I'll show you again. They all contain a backboard. They contain a splint pack with an assortment of quick splints, ready splints. They have C-spine stabilization. They have a pillow. They have 2 blankets to try to stave off hypothermia. And they have, we refer to this as a burrito pack, so that we can cover up the patient so that as we are skiing them down the mountain, we're not spraying them with a whole bunch of snow. So that's what's in a toboggan. And if we look at that map of the mountain again, you can see that if you get into an accident on Rattlesnake, some ski patroller is going to actually need to take a toboggan from the top of the mountain up here, and they're probably going to ski it maybe down the rock, maybe down this green run, and then they're going to come into Rattlesnake, because that is the toboggan that is above this run most closely. Similarly, if you get into an accident in Lower Green Canyon, they're going to come and get this toboggan. Someone's going to have to ski down from above, grab that toboggan, and come down. So anytime we have an accident reported on the mountain, often it happens because someone tells us, they call on their cell phone, they do whatever. So sometimes they shout at us when we're sitting on the lift. So we will have a patroller go to the accident site, ascertain and evaluate what's actually happening with the patient. Then they will get on the radio and call other patrollers for support. So they may get on the radio and say, I am now at the Lower Green Canyon incident, and I do need a toboggan and additional patrollers for transport. In which case, a patroller from either the top shack where they're waiting to be activated, or potentially someone who just happens to be skiing somewhere above them, will ski down, bring that toboggan to them. They can stabilize the patient with the splints and then ski them down to our base area down here at the bottom of the mountain, marked with the little red cross, where we can then choose to put them in an ambulance, send them in their own vehicle, or even you can see we have a helicopter landing zone established near the bottom parking lots. If the person is in more distress and needs, let's say they have a femoral fracture and they are going into shock, they're then going to need additional means to treat that shock. So we have a trauma pack at our upper patrol shack, which contains oxygen, ambu bag, oral and nasal airways, really basic suction. Here's our Kendrick traction splint for that femoral fracture. We've got additional splinting material, blood pressure cuff, stethoscope, things we would need for a patient who is in more distress. And you can see my friend James here has our trauma pack as well as then our AED pack on his back to ski down the mountain. That is really bulky to ski with. It messes with your center of gravity. So what will frequently happen there is they will call in, we have an incident, we need both a toboggan and the trauma pack. And they'll send one patroller with the trauma pack, AED if necessary, and a different patroller will take the toboggan from the nearest site. But you can appreciate that this becomes a bit of a logistics game because you're figuring out who's the nearest patroller to the nearest toboggan, who do we need additional supplies from above, and then what patrollers are moving back up the mountain to replace the person above, just in case there's another call and somebody needs to come down. We do have multiple trauma packs, and you can see these little red toboggans. We have got them scattered all over our mountain to try to put them in key places to need to then be able to bring down to any trauma. The thing about skiing is the only direction is down. You try not to ski uphill. This is our base patrol area. It is a really simple first aid room. It has a lot of splinting and dressing and sling and swathing supplies, because of course, most of what we see are orthopedic type injuries. It has, we make a lot of official ice packs, and that's all there. We also have a garage bay right next door, so ambulances will pull right up if we need to load someone into an ambulance. So let's go back to the beginning. This is our day, Sunday, March 15th, 2020. I'll tell you, this picture here is not just a random picture. This is what we call the Cowboy Classic. It is an event that is always held on the second Sunday in March at Pebble Creek. It happened yesterday. And it involves crazy people with one skier riding a barrel and two skiers guiding them through a set of gates as they ski down in a relatively green area, but there's typically alcohol and a fair amount of insanity. So that was also going on the afternoon of Sunday, March 15th, when we got this radio call, CPR in progress, please respond. Sorry, rearranging the windows on my computer. So this incident happened in the North Bowl area. We got a cell phone call that a skier had been buried in an avalanche and had been recovered, and that CPR was in progress. And their report was that it occurred in Canal Street. Now, when you're within the ski area boundaries, of course, all of the runs have well-established names. When you were outside the ski area boundaries, you can see we've got a couple named areas over here. North Bowl is particularly famous for having a bunch of colloquial local names for all the various chutes of the various canyons that come down there. So it gets a little tricky. So at 1:16, that cell phone call came in. The patrol was mobilized to respond. They needed to pick up avalanche packs. They needed ideally a specific toboggan that could handle this sort of out of bounds terrain more. This is, of course, a summer picture of the mountain, but you can see that green cat track is actually a road coming down the mountain to our base area. My friend Luke, this is our patrol building. He was actually down here with the Cowboy Classic going on right down here. He was actually right about here on the mountain. He needed to ski down and then take the lift all the way to the top to be able to respond to this incident. Luckily for us, we actually had patrollers with the appropriate avalanche gear to form a hasty team to initially respond to this avalanche, who were already located at the top of the ski area. So they mobilized as Team 1, the hasty team, to go out and find this incident. That's the first problem, as well as seeking out a safe route, or a safer route, knowing that there had been an avalanche. There's concerns about hang fire. There's concerns about additional avalanche activity in the area. And we, of course, do not want patrollers involved in further accidents. We don't need more victims. At 1:17, we got a few more details from the people on scene. The skier had apparently been wrapped around a tree. He was skiing with two companions. They immediately dug him out. And it just so happened that two bystanders who are actually nursing staff at our hospital shortly thereafter skied into the area and initiated CPR. The concern from the Hasty team was that the avalanche danger was high. There's a particular cornice that's referred to as first scary monster. They noted that it was unstable and suggested that the second team would need to find a different route to the scene of the avalanche here at the red X than team one had taken. The report that we got just a minute later was that they had been doing CPR for a total of 30 minutes with no response. And knowing that those were nursing staff members and this was good quality CPR. At 1:28, we got back to them and said, please do continue the CPR until we arrive. By that time, 12 minutes is the ride on the chairlift from bottom to top. So at that point, Luke had gotten the AED and had started traveling out to be part of the second team to get on scene with additional supplies. At 1:34, we called in a helicopter and instructed them to use landing zone 1 here at the bottom. So just to give you an idea, this is the traverse route from our patrol across the top of Pebble Creek. While this is a well-established run, it's a bunny trail. So we have patrollers who are skiing this traverse through the forest, and then they're coming out to our ski area boundary. These photos were taken almost a year later. This was a much lower snow year when I took these photos, so it was much snowier then. But you can see our clearly marked ski area boundary with the warning that you are passing the area of ski patrol services, including avalanche control. But again, you can see the patrollers traversing out here. So team 2 is headed out. Now, initial call went in at 1:16. 1:28, they started heading out with the AED and additional sled and other equipment. At 1:35, there is a call in that there is another incident in South Bowl, this area over here. And at 1:36, there is now an incident associated with the Cowboy Classic here at the base area. So we now have the 12-person patrol team that day addressing 3 separate incidents at the same time. So we are now doing a lot of incident management to put people in the right places at the right time. 1:40, they're working on preparing the landing zone for the helicopter. 1:41, we have a patroller on scene at the South Bowl incident. 1:42, we have an ambulance on scene, and they're going to help us set up the landing zone, as now all of our patrollers are busy with other incidents. 1:45, we now have our third team at the ski area boundary ready to go out and help the rest of the patrollers get this patient out of this area, because now they have to, once they've stabilized him as much as possible, they need to ski him out of Canal Street, which I'll show you a video, is its own hazard. We then By 1:48, the barrel racing patient was at our base patrol room. At 1:53, they had gotten the patient, they had gotten the team on site and were ready to start getting him out. At that point, you can see CPR had been in progress for almost an hour, and the patient had significant trauma. The decision was made that they could not ski him down with continuous CPR. So they elected to do intermittent CPR. They were getting, they had the AED hooked up to the patient, so they decided to do CPR, and then when it was time for an AED reassessment, they would then ski the patient in the toboggan until the AED had finished its assessment, elected to shock or not. And when the AED was done, they would then pause with the toboggan to resume CPR for 2 minutes and continue as such with intermittent CPR, pausing, resuming as they could to attempt to get the patient out of this area while still doing at least some CPR. 2:03, they were, 1:58, the injury in South Bowl here. We need a snowmobile to traverse that patient to our base area, and they had met the snowmobile and had started to bring that patient into the patrol building. We were also at 2 o'clock mobilizing patrollers to meet the Canal Street team here near the bottom. There's actually a slight uphill area, and they needed to arrange a group of patrollers to haul the toboggan uphill to an area where it could meet the snowmobile to then bring the patient up what's essentially our bunny hill here at the bottom of the mountain to the base area, to the helicopter. 2:07, the South Bowl incident got to the patrol room and got straight into an ambulance. And 2:16, they had left. At 2:17, the team was way down where we refer to the bottom of the gut, so they were ready to start bringing the patient up. At 2:48, the Canal Street patient had arrived. Interestingly, at 2:22, the helicopter had arrived, was in the landing zone, and actually took off because of poor weather. So at 2:48, when they finally got the patient to the base area, they were placed in an ambulance and taken to Portneuf Medical Center. And at 2:51, all the patrollers were back to doing regular patrol work. I didn't mention 2:20, the barrel race patient was placed in a personal vehicle and left the patrol area. So all of that was happening over the course of 1:16 to 2:51 in the afternoon. 3 different incidents, extricating an out of bounds avalanche, an incident here in our South Bowl area that ended up going by ambulance, a barrel racing incident that ended up going by personal vehicle. That was a lot of stuff for less than 2 hours of time. These are photos from the next day with the avalanche expert who was sent out to record the incident. You can see him, he's standing here under the cornice of the avalanche. And you can see the scale of him measuring the height of the cornice. And again, just a little closer as he was assessing the snowpack and taking his management measurements. This was a pretty big event. This is a video of patrollers during a training exercise. Like I said, this was a much lighter snow year last year, but this is them taking a toboggan out of almost the exact same drainage coming out of Canal Street. So you can appreciate, that year there was much more snow, but this is a very narrow area, very technical skiing, a lot of rocks and trees and so on. And you can see why it takes some time, and it's very difficult to continue doing CPR the entire time you're bringing someone down that. So after that amazing hour and 20 minutes, they did a critical incident debrief with search and rescue in the sheriff's department. They did a quick team debrief and made a plan to follow up. The things we learned that day: backcountry rescue is not as fast as we'd want it to be. For everything that was happening, for the good luck of having people with avalanche packs right there at the top of the mountain ready to go, we wish it was faster. This was unbelievably lucky that there were medical staff right there on site immediately after the event. Friends were along to immediately dig the victim out, but it still took forever. There are significant physical demands to work in this environment. I mean, skiing that run with the equipment, with the toboggan, with a patient, all of those things, that is difficult. And to realize that the friends who had just witnessed this avalanche, that the bystanders who had just done CPR for an hour until other patrollers got there, also had to ski out of that area too. Decisions about the medical care of our patient will be affected by the restraints of our environment. We cannot do continuous CPR and ski in those conditions with a toboggan. It just doesn't work. And sometimes we are going to need to choose the most effective way to get the patient out of that situation and fastest to extrication, which may not be the highest standard of medical care. A lot of the ski patrollers and the people who were there knew this person. We are a relatively small community, so he was a frequent skier. He had a season pass. Well, people maybe didn't know his name, they knew his face, and that hurts. That is hard. And frankly, we have a culture problem in our first responder community, and frankly, in our medical community at large, about the emotional toll that this whole everything takes on the rescuer. And we need to be able to talk about the fact that this is hard. So like I was saying, that afternoon, there were 3 concurrent incidents. One of them, the avalanche, was a fatality. The South Bowl incident was a bad enough injury that the patient went via ambulance to the hospital. It was a back injury. There were a total of 15 patrollers working that day. It was a weekend. We always staff at least a dozen. There were 15 people. All of them were mobilized to attend incidents, and some even multiple. So some of the people who responded to the barrel race incident ended up going down to the bottom to help haul that toboggan uphill out of the Canal Street incident. And all of these people were volunteers who, after that happening on their Sunday afternoon, then had to go back to their regular jobs on the next day. So what we did was we scheduled another debrief with them 3 days later. And Luke and I had a vague sense of this model from the Responder Alliance, from the work of Laura McGladrey in Colorado. And we abruptly familiarized ourselves much more deeply with it in order to train our patrollers. I brought in a colleague from the residency program who's a psychologist, Dr. Verena Roberts, to come to that meeting with us to offer support and resources for patrollers who were really struggling. And we tried to normalize for everyone in that room that it is okay to be hurting after doing this. We invited anyone who was there that day who frankly wanted to come. So we had patrollers, we had people who had been working in the office who had listened to the radio traffic at the mountain that day, because of course our office is, you know, doing the log of radio traffic that I was just reading from. We had anyone who, no matter how peripherally, may have been touched by this incident. And we talked about the fact that it is perfectly normal to be having some symptoms of a stress injury after dealing with this, not only the fatal avalanche, but even just the stress of having 3 incidents, all of this going on all at the same time. So people who may not have been involved directly in the avalanche, but who were dealing with the South Bowl incident and were still listening to all of the radio traffic, feeling the stress of having to do that all at the same time. Interestingly, in that evening, the person who was the most affected was actually the person who listened to the radio traffic. And perhaps the person who had the least training about dealing with any of this. You know, their job is simple. They're an office staffer and they just write down the radio traffic. But they were not prepared to deal with the fallout of listening to all of us talking about this. We had, I have to smile because, you know, we had 20 people in that room, a lot of bearded, you know, sometimes grumpy, surly, macho patrollers. And we actually got them to talk about feelings and talk about how they were doing. We started with, what color are you? And if they were comfortable sharing more about how this was impacting them. And then we opened it up to, if they felt, we would connect them with resources. The next part of this model for response is a 3-3-3 exposure protocol. So it suggests 3 days post-incident, doing this stress continuum check-in as we did, normalization education. It is okay to be hurting. It is okay to be yellow or orange or red after an incident like this. If people are able to take a day off of work, if they're able to start counseling, whatever it means to try to move themselves in a green direction, as well as just being aware of the fact that they're struggling. Then moving on, and 3 weeks later, checking back in with people. The check-in that they're referring to here is this traumatic stress questionnaire, and specifically asking them these questions. We're looking for a score of 6 or greater to be a trigger that there should be an intervention at that point. That 3 weeks later, this should be falling off. But if they're still experiencing 6 or greater, that we should be strongly recommending counseling, seeking medical help. And you can see, again, resources. And we did have several people involved in this day who chose to take advantage of counseling resources. and again, simply normalizing the fact that, again, we don't necessarily expect people to be completely back to normal. We're hoping that they're improved, but they still may be saying yes to several of these questions. And again, actually checking back in with people 3 months later, which Luke did by phone, calling everyone who was involved to again ask them, what color are you? How are you doing? To again, if they need it, consider even further check-ins, connection. The beauty of this model, especially for something like ski patrol, search and rescue, fire teams, is that this is seasonal work. So we often forget, this happened in March. We close as a ski area at the end of March. So we start losing track of our patrollers. They disappear for the summer, essentially. So it's an effort to set a reminder on your phone, check in with them in 3 weeks, check in with them in 3 months. But it really helps to normalize this sort of stress and help people to identify it and make choices to intervene if necessary. I mean, I'm happy to report that everyone who was part of the Canal Street incident and everything that happened that day are still on our patrol. Nobody didn't come back the next season. No one chose to quit patrolling or quit working at the ski area after being involved in this high stress day. Ironically enough, this week, 2020, was also when COVID really hit our medical community hard here in Pocatello. So I was dealing with residency contingency planning with the onset of the pandemic in the same week that I was helping the ski patrol deal with a fatal avalanche. I don't think I'll ever say that again in my life, or at least I hope not. Pandemic and fatal avalanche all in 1 week. But it also occurred to me that this model of stress applies to us as medical providers too, and can be really beneficial within our clinics, within our hospital. And I've actually used this model. We had a fatal heart attack in our clinic last summer. And we use this model to intervene with our clinic staff, the residents, everyone who helped treat that patient in our clinic. And again, it really helped to have a simple model for framing and intervening. Again, interestingly enough, it was one of the more peripheral people to the incident who was the most traumatized by it. So don't close yourself to the option of thinking about the people who are perhaps less obviously involved. So this is, again, I got those resources from the Responder Alliance. They do online courses. They actually have an ECHO project with the University of Colorado for healthcare providers. I would really suggest looking at those if this is something that interests you. And I will open it up for questions and conversation.
Thank you, Dr. Weinhold. That was a very, yeah, that was a very emotionally intense presentation actually to watch. And I can't even imagine what you and your team went through on that day. So thank you so much for sharing the lessons learned and these perspectives. We did have Dr. Tubbs mention after your first prompt when you started that he's been a member of the Ski Patrol, but not the director. So just making sure you saw that. And then I would invite any other participants to either unmute yourself and ask a question or type the question in the chat. And I will share that I have recorded today's presentation. I don't record these regularly because of the time it takes to get them up and posted. And this is not an enduring credit, but I am going to be posting this presentation to the IAFP website sometime in the next couple of weeks, and we'll let our members know where to find it on the website once that's established, so that you can share it with colleagues that maybe weren't able to attend today. So we have a question from Dr. Conger. What was the victim's cause of death? Trauma?
Yeah, we presume that the cause of death was trauma. He was, as I said, conveniently skiing with two friends, as one should. And so they actually quickly unburied him. He was not deeply buried. And he was found wrapped around a tree. So it was presumed to be trauma.
And then Dr. Tubbs said, very good and thought-provoking, and that would have been a very frustrating experience given a lack of good options.
Yeah. And part of this is, when you guys are working in an ER and you've got a local ski area, I really want you to realize sometimes what it takes to get those patients to an ambulance. And that it may not be perfect. But there's actually a lot of logistics in simply getting that person to EMS services.
That's a very important point on that connection there. Any other questions, either in the chat or by unmuting and sharing your question directly? Well, Dr. Weinhold, again, thank you so much for this really important talk. If you would mind sending me a PDF of the presentation for those that will be receiving their CME certificates, I will include the PDF in the presentation. And as I said, I will make sure that the recording link is shared with all IAFP members sometime in the next couple of weeks. Is there anything else you'd like to say before we close up?
That is about it. I see another note. The radio log person is someone who cannot do anything to help. At least that's probably why they feel so bad. I would agree. Some of it is that lack of agency, as well as, yeah. So, the incident in my clinic, I found out that the person who was the most traumatized was someone who had a personal history that, fell into that event was triggering for them. It is such a mix of things. But I really like this model for, you don't have to be a healthcare professional. You don't have to be an expert. You don't have to have a psychology degree to be able to use this to reach out. This is actually currently the entire city of all of the resources in Jackson are using this together. So their search and rescue, their ski patrol, their EMS, all use this model for training their staff and find it really useful. This is also being implemented in Colorado. I know that, the Red Cliff Foundation, which is here in Idaho for the support of river guides, etc., who are struggling with stress, they're using this. I would just really recommend it to you.
Thank you so much for sharing those resources. And I also just want to thank you for your leadership as a first responder, and just a reminder for everyone to express gratitude to our first responders on lots of levels. So thank you so much. Our next Grand Rounds presentation is April 10th. It will be with the Rural Health Fellow from Kootenai Health up in Northern Idaho. I don't yet have the presentation topic, but I'm sure it will be great. Same time on April 10th. We hope to see you all then. And another reminder that the IAFP annual conference is taking place May 5th and 6th in McCall at the Shore Lodge. Residents and medical students can register free, and we will have some free lodging options for residents and medical students as well. More information to come on that soon. Thank you again, Dr. Weinhold, and I hope everybody has a great day.